Good afternoon to you all. Welcome you all for the webinar of this month. Today, the topic is on parenteral nutrition, biochemical monitoring and metabolic complications. Today's the speaker is from UK, Dr. Alison Kelly from the Glasgow Royal Infirmary, UK. Dr. Alison Kelly, BSc, MRCP, FRCPAC, and she trained in chemical pathology and metabolic medicine in the west of Scotland prior to appointment as consultant chemical pathologist at the Queen Elizabeth University Hospital and subsequently Glasgow Royal Infirmary. Her clinical interests include lipid, mineral metabolism, and clinical nutrition. She has developed extensive experience in prescribing and monitoring parenteral nutrition for adult patients, working alongside a multidisciplinary team in a variety of clinical settings, and currently coordinate parenteral nutrition provision for the Beats and West Scotland Cancer Centre. So we are today very grateful for her for joining with us for the College of Chemical Pathologists of Sri Lanka for the webinar series on the topic of parenteral nutrition, biochemical monitoring and metabolic complications. So over to you, Dr. Alison, for the lecture.
Okay, well, thank you very much for the kind introduction. It's absolutely lovely to be coming to you today from an unusual sunny morning in Glasgow. I'll just get the slides up and we'll get started. Okay, can we all see that okay?
Yeah, yes, we can see.
Perfect. Okay, so parenteral nutrition. Parenteral nutrition is a bit of a mystery to a lot of people because I guess it's a very subspecialist area. And I mean, certainly when I started training, this bag hanging by a patient's bedside was always a mystery to me. So today, first of all, I have no disclosures with regards to this, but today what we will do is we'll have a chat about parenteral nutrition in general. You know, what is it? What's in it? Why would we give it? And then we'll come more on to the side which is relevant to us as chemical pathologists. So we'll look at some of the acute complications. We won't be able to be exhaustive because of time limits, but we'll look at glucose, we'll look at triglycerides. We'll have a bit of a chat about refeeding syndrome and how that might present in our patients. And we'll have a look at some of the chronic complications, specifically intestinal failure associated liver disease, metabolic bone disease. And then we'll have a look at biochemical monitoring of parenteral nutrition and how the lab can support that. So why do we give it, first of all? Parenteral nutrition is a life-saving treatment in those with intestinal failure, but it's also a bit of a last resort. So there are multiple different definitions of intestinal failure, but probably one of the main ones that's widely recognised comes from ESPRIN, the European Society for Parenteral and Enteral Nutrition, and that's gut function below the minimum necessary to maintain macronutrient, water and electrolyte requirements such that IV supplementation is required. And by IV supplementation, that can mean full total PN, it can mean electrolytes only, it can mean some support intravenously, whereas otherwise the patient is fed enterally or can eat. And then PN should be considered in patients who are malnourished or at risk of malnutrition and meet either of the following criteria. So inadequate or unsafe oral or enteral nutritional intake. So unsafe might be somebody, for instance, who has an unsafe swallow or who has a trauma patient where putting in an enteral tube to the stomach is unsafe because of head injury, base of skull fracture, and a non or poorly functional, inaccessible or perforated gastrointestinal tract, so that the potential causes of that are very wide-ranging. So I know we're here to talk about parenteral nutrition, but if ever I'm talking about parenteral nutrition, there's one point I always like to stress, and that's if the gut works, use it. So we used to quite often call parenteral nutrition TPN, total parenteral nutrition, but we've moved away from that. And that's because so many patients, even who need intravenous support, will also get a degree of enteral or oral feeding. And that's because maintaining the gut, maintaining mucosal integrity is so very important to both preventing complications associated with intestinal failure and maximising the ability for the gut to recover. So intestinal failure, we tend to split into 3 types. So type 1 is short-term, requiring acute parenteral nutrition support as a bridge to getting enteral function back. And by far the most common cause of that is a post-operative ileus. So a lazy bowel, essentially, after major, generally GI surgery, but also some prostate bladder procedures. And that will generally resolve itself over a period of time. And sometimes we give, say, a week of PN just to facilitate nutrition during that process. Type 2 is a medium term, so usually more than 28 days, but where you're expecting the patient to regain some function. And for instance, a fistula after surgery might be an example of this, where a patient needs a couple of months of parenteral nutrition. So probably one of our most common causes is related to surgery, maybe for inflammatory bowel disease, something like Crohn's, with fistulas developing. But also you might be more familiar with things like gastrointestinal TB, where stricturing is a potential complication. And type 3 is your long-term intestinal failure, requiring chronic parenteral nutrition support. And these are the patients who've had multiple resections and have a short bowel, so generally less than 200 centimetres of small bowel remaining, or something like a widespread motility disorder. And these patients, not to say that they won't come off PN eventually, but they require often into years and sometimes lifelong parenteral nutrition support. So before we can look at how we're monitoring it and the complications, we need to know what's actually in that bag, what's in there, what are we giving into the vein of these patients as nutrition. So most of our bags, so certainly for adults, are they're commercially bought in bags, so either all in one or bags with different chambers, or PN can be made up from scratch from different basic components. And those basic components comprise your macronutrients, so carbohydrate, which is generally glucose, dextrose, an amino acid solution, which we tend to talk about as nitrogen rather than protein, and also a lipid emulsion. Within that, you also have micronutrients added in, so water-soluble vitamins, fat-soluble vitamins, and trace elements. And then the patient's fluid requirement made up with crystalloid, either given as part of that full bag or given as supplementary crystalloid over and above what's in the parenteral nutrition itself. So that is an example of one of our kind of commercial bags. So this is it's quite an old one, as you can see, with an expiry of May 2013, but generally the design hasn't really changed much. And you can see 3 different compartments there. So an amino acid compartment, a glucose solution compartment, and a lipid compartment. And these perforations down the middle are loose perforations. So when that bag is pressed in pharmacy, pressure put on it, those perforations burst, and those 3 compartments are allowed to mix. And then after that, that mixture will be stable for variable amounts of time, depending on the manufacturer, but generally 48 to 72 hours. The lipid compartment in this particular bag comes from olive oil and soybean oil, but the composition of the lipid is relevant in potential clinical scenarios. So I'll talk about that a little more in a second. So I mentioned we talk about nitrogen. When it comes to nutrition, most people are more familiar with the concept of protein. But nitrogen in PN is generally just another way of talking about protein, but in a more basic kind of amino acid availability for muscle building. So your nitrogen requirements are about 0.13 to 0.24 grams per kilogram per day, dependent on clinical picture, catabolism, metabolic stress, and that that's about 0.8 to 1.5 grams of protein a day. So a gram of nitrogen is just 6.25 grams of protein. And once you know that, you can switch from one to the other pretty easily. And the main role is provision of amino acids for lean tissue maintenance and production of plasma proteins. There is a little bit of energy provision from nitrogen, but generally we like to save that for lean tissue. So energy is mainly coming from carbohydrate and lipid, and there are advantages and disadvantages of both, as you can see from this table. So glucose infusions are pretty cheap. They're readily usable, readily available, and different concentrations can be used to adjust volume really quite easily. Especially in a stressed patient, too much glucose can predispose to hyperglycemia. These are high osmolality preparations as well. So in terms of delivering them, you're going to need quite often a tunneled catheter, a Hickman line, or a peripherally inserted central catheter, a PICC, because if you try and give that through a midline or a cannula and it extravasates, high osmolality solution is going to potentially cause problems. High concentrations of glucose as well may also impair hepatic function. So if you're exceeding the ability of the liver to oxidize glucose. Lipid, on the other hand, provides essential fatty acids. And if you give a parenteral nutrition patient who's receiving very little nutrition from anywhere else, pure glucose with no lipid, you'll start to get clinical features of fatty acid deficiencies within anywhere from 2 to 6 months. It's energy dense, so lipid is generally 9 grams or 9 calories per gram, whereas glucose is 4 calories per gram, and glycerol in some preparations might even give you a little bit more than that. So it's energy dense, and it's low osmolality as well, so it doesn't have as many problems in terms of making up the solution with volume and osmolality. The stability in some regimes can be difficult. You need a pharmacist generally, or somebody who knows their stuff in terms of what's compatible with lipid emulsions. There's always a risk of hyperlipidemia when you're putting an emulsion straight into the vein. And also it may compromise hepatic function, but it tends to be a kind of longer term compromise that's associated with lipid fraction. So this is taken actually from a Sri Lankan document, and it just gives you an idea of some of the calculations that may be involved loosely in developing parenteral nutrition from scratch. So start off by calculating an energy requirement, and a very kind of simple way of doing that is to say 20 to 30 kilocalories per kilogram per day. We generally wouldn't do that with our patients. We have just specialist dietitians as part of our multidisciplinary team, and where calorimetry isn't available to us, which is most scenarios, they will use predictive equations, such as those based on Schofield or Henry, where they take the patient's scenarios into account, and they also add on a factor with regards to how stressed they are and what the clinical picture is, and they then calculate a range of energy and protein requirements that we can then work to when prescribing parenteral nutrition. So 20 to 30 calories per day, if you don't have that available to you, but generally predictive equations or more direct methods of calculating energy requirements would be superior. Carbohydrate there has been calculated as 50 to 55% of calories, and there's a calculation there using 50% dextrose. There's a calculation for fat there using lipofundin. So lipofundin is a combination of soybean lipid and medium chain triglycerides from coconut oil, and a calculation for fat. Protein requirement using aminoplasmin and amino acid solution, and then a fluid requirement on top of that with the required calculated electrolytes. And so that gives you an idea of how a bag might be made up if it's made up entirely from scratch and not bought in from an external manufacturer with then electrolytes added. So I mentioned that the lipid is important. So traditionally in PN, it was long-chain triglycerides that were used in these lipid emulsions, so usually from soybean oil. And intralipid is still one of the main lipids in a lot of our bags, and that is predominantly soybean oil. The concern with that is it's mainly polyunsaturated fatty acids, and these are pro-inflammatory and potentially immunosuppressive in conditions of stress. And also prolonged or overprovision of these lipids can contribute to hepatic cholestasis over time. So when we see N3 and N6 polyunsaturated fatty acids, it's really just to do with the structure. So it's where the double bond is from the N-terminal end. So on the right, you have these N6 linoleic arachidonic acid pro-inflammatory, whereas there's a bit more of a move now towards anti-inflammatory N3 polyunsaturated fatty acids, such as those on the left in lipid infusions. So some of the alternative preparations available exhibit anti-inflammatory effects, and they may help reduce long-term effects on the liver. So medium-chain triglycerides, usually from coconut oil, olive oil, fish oil, and then combination products. So SMOF lipids, so SMOF stands for soy, MCT, olive oil, fish oil, and that is a combination. And in terms of good, robust evidence for use of these lipid preparations, that's probably still lacking, but there are a lot of case series, and the view of most experts in the field is that there is definitely benefit to using these, particularly in certain scenarios such as liver issues, long-term home parenteral nutrition, and neonates in some cases as well. So there are multiple potential complications to parenteral nutrition. A lot of them are related to the method of administration to the line, how you actually get it into the patient, and those are on the left. But we are going to concentrate on the metabolic complications, those related to the feed itself. And this is them on the screen on the right. So we don't have time to go through all of these. Some of these are more pertinent to particular patient groups. So my training is in adult medicine, so I'm going to stick with what I know today. But electrolyte disturbances, things like hypernatremia and the same token hyponatremia in premature neonates are really very, very important. And in these very tiny patients, there's a lot more involvement in changing the formulation of the PN and the electrolyte requirement day to day in order to avoid complications than there would potentially be for an adult who's that bit more stable after the initial acute phase. So hyperglycemia, high triglycerides, and electrolyte balance. When you're first starting parenteral nutrition, in most patients, we're doing it in a kind of acute environment, if you like. So certainly our short-term parenteral nutrition patients, most of them are post-operative or very malnourished, or they're coming in a generally quite acute situation where you have an illness with cytokine release, interleukins, tumor necrosis factor, and increased counter-regulatory stress hormones, adrenaline, cortisol, glucagon, growth hormone. And all of this is kicking in this early catabolic state where you're having breakdown of adipose tissue, lipolysis, you're having decreased peripheral glucose uptake, you're breaking down muscle, you're breaking down hepatic and skeletal muscle glycogen, and then you've also got hepatic gluconeogenesis going on with the increased substrate, so production of glucose from glycerol, alanine, lactate, anaerobic metabolism. And all of this results in increased circulating glucose and free fatty acids. But the other thing that's going on in this acute situation is this relative insulin resistance. So you have all this substrate floating around, but in terms of peripheral reuptake, there is this push against that because of insulin resistance. So what are we then going to do when we start feeding people? We're going to give them dextrose. So we're going to give glucose. Dextrose is the main energy source in parenteral nutrition. So obviously the tolerance of that's going to be very dependent on what you give and how fast you give it, and also how sick that patient is. So if you have somebody who is already hyperglycemic and we then give more glucose, that can potentially cause problems. Hello? Sorry, am I okay to continue?
Yes. Yeah.
Yeah, okay. So the liver's ability to process this extra glucose may be reduced in metabolic stress. So we mentioned insulin resistance. Also, these patients may be getting catecholamine vasopressors in order to maintain their blood pressure. They may be on large doses of steroids. They may be elderly or very, very young, in which case their ability to handle this glucose load is impaired even before the stress response. Our aim is generally to keep plasma glucose less than 10 millimoles per litre, or less than 180 milligrams per deciliter, and that is using insulin if required. And then glucose administered to ICU patients should not exceed these rates, and that's an ESPEN recommendation. It's rare in practice that we would sit and calculate that unless we were giving something very different to a kind of standard bag that we have clinical experience with using. But that as a general guide is there to help reduce excess glucose load in these very stressed patients. So uncontrolled hyperglycemia has multiple potential detrimental consequences to the patients. So fluid and electrolyte imbalance due to osmotic shift, and then also potentially causing issues with our results as well. So very highly osmotic blood may cause osmotic shifts resulting in hyponatremia, for instance, and difficulty interpreting that and getting a full clinical picture. I've thankfully never seen a full-blown hyperosmolar hyperglycemic state as a result of PN, and I sincerely hope I never do, but it is potentially there if PN's not monitored very closely. Hypertriglyceridemia, I'll talk about in a minute, but a very high circulating glucose is a secondary cause of hypertriglyceridemia. Hepatic steatosis, even transiently in the early stations, may be related to very high glucose. And respiratory decompensation, again, in extreme cases. And these patients are often susceptible to infection already, but you increase the glucose load and that's going to exacerbate things. So high triglycerides as well are not uncommon in these patients. So lipoprotein lipase activity, your endothelial surface enzyme that is there to break down triglycerides, that activity is reduced in stressed patients and in renal insufficiency. So you're already going to have reduced breakdown of triglycerides and more circulating. The infusion rate of the fat emulsion, similar to glucose, can, if you're not careful, exceed the capacity of plasma fat clearance. Glucose overfeeding as well is a secondary contributing factor. And then also these patients quite often have secondary causes of high triglycerides anyway. So they may already be diabetic, potentially with poor control. Certainly in the west of Scotland, we have significant issues with obesity and alcoholism in our patient population. And pancreatitis is both an association and a potential consequence of severe hypertriglyceridemia. Pre-existing hyperlipidemias, very occasionally you'll get a patient with a primary hyperlipidemia or a pre-existing metabolic syndrome where controlling their triglycerides is really very difficult. and also drugs, including steroids, immunosuppressants such as cyclosporin and propofol. So propofol is a potent sedative used in intensive care, and it in itself is a lipid emulsion with 1.1 calories per mil. And patients can be on fairly heavy doses of this, so it's not unusual to see a patient on 15 mils of propofol an hour. So over 24 hours, that on top of parenteral nutrition, you can have 200 to 300 calories from propofol alone, and you add that in on top of fat emulsions you're giving in a parenteral nutrition bag. So just as a kind of illustration of some of the things here in the acute phase that can be tricky, this is a patient of ours from several years ago now, and he was admitted with hypertriglyceridemia and severe acute pancreatitis with multi-organ dysfunction. So the surgeons had quite a time with him in theatre. They drained 1,700 mils of peritoneal fluid, and they debrided a lot of pancreatic necrosis. He had a grossly dilated stomach, grossly dilated edematous bowel and omentum. So his gut function was really left a lot to be desired. Because of all of this internal swelling, he had to be managed with an open abdomen for a period of time, with the susceptibility infection that is associated with that. And he required further surgery to resect more pancreas a couple of months later. So after initial assessment, his requirements from our dietitians were around 1,700 calories and around 12 grams of nitrogen per day. And that's if you allow from the calories he was getting from a nasojeginal feed. So tube into the nose, bypassing the stomach, going into the jejunum. So we didn't know whether he was really tolerating that or absorbing that, but given that, that was going in and not coming back out again, we were assuming that he was absorbing that feed. His triglycerides were 3.9 millimoles per litre, so the upper limit of our kind of fasted reference range is 2.3. Generally, we can tolerate up to 4.55 millimoles per litre, about 400 milligrams per deciliter before we start getting a little bit nervous. And this gentleman's CRP was 300 milligrams per litre as well, which renders much of a micronutrient screen completely uninterpretable. And I'll mention that again in a later slide. So we started him on PN with a slow titration of his calories, 5 grams of nitrogen, 9 grams of nitrogen in increased calories after 48 hours, 11 grams of nitrogen at 5 days. To cover bases, he had double provision of his trace elements for the first 10 days because he was very severely malnourished. He had continuing of his enteral regime, daily triglycerides, and 4-hourly capillary blood glucose monitoring. So the issues we ran into, his phosphate continued to rise despite normal renal function. His triglycerides continued to rise up above 5 millimoles per litre. We switched him between fat-free PN, which reduced the triglycerides but had a higher phosphate load and increased the phosphate, and electrolyte-free PN with no added phosphate, but our particular preparation had a fat component. So if the phosphate comes up, the triglycerides came down, and the other way around if we change preparation. He had really quite high insulin requirements, 3 to 7 units per hour. He continued on his NJ feed, but he couldn't have pancreatic enzyme supplementation, Creon, because the tube was blocked, so we had no idea if he was absorbing that or not. And also his requirements, because of metabolic stress, and once he was extubated, his calorie requirements increased, so that had to be recalculated on a regular basis. And then you can see from some blood results there, this is not unusual in these very sick patients who need to be on parenteral nutrition for a number of weeks. So his alkaline phosphatase is raised, although we weren't overly worried. That was secondary to the parenteral nutrition, and also his bilirubin was still normal, but his adjusted calcium was climbing and his phosphate was climbing. So avoiding hypertriglyceridemia from over providing fat and glucose was on our mind. Avoiding very severe hyperglycemia, avoiding hyperphosphatemia, how to progress his enteral feeding, and also his changing nutritional requirements and how we were going to meet that. So that is a kind of real world example of why biochemical monitoring in PN is so very important, and some of the issues that clinicians might face while trying to manage it. So I imagine the vast majority of you will be familiar with the refeeding syndrome, but it's always useful to revise. So if we overfeed an unwell, particularly stressed or malnourished patient, that can result in full-blown refeeding syndrome. It further depletes your micronutrient stores. There's an increased oxygen consumption and CO2 production, with issues with ventilation potentially, and also a relative hyperglycemia with insulin resistance. So this is another case, and this is a fairly extreme case from the literature, but it just illustrates how bad refeeding syndrome can be. So this is a lady with a poor compliance with a gluten-free diet, admitted with severe diarrhea, malnutrition, and a kind of general decline. Her BMI was only 14 kilograms per meter squared. Clinically dehydrated, signs of hypovolemic shock, a low albumin, which could be indicative of either acute inflammation, the acute illness, but also potentially an element of malnutrition as well. A degree of renal impairment with a creatinine clearance around 50 mils per minute, and a hypokalemic metabolic acidosis. And then calcium, phosphate, and blood glucose at that stage on admission were normal. So she was initially treated with intravenous hydration and electrolytes. Oral nutrition was restarted alongside IV dextrose. It wasn't clear as to why the parenteral feed was started, if that was just required additionally, given she was tolerating some oral nutrition, but a low-calorie parenteral feed was started on day 3. And then on the next check of blood results, we have very severe hypokalemia, severe hypocalcemia, which is likely to be related to a low magnesium, although that result wasn't given. Severe hypophosphatemia at 0.3 millimoles per litre, and also this new hyperglycemia, as well as a respiratory alkalosis on the blood gas. So the outcome of this case, unfortunately, was not very good. So this lady developed a pericardial infusion, severely reduced left ventricular function. She required mechanical ventilation, inotropic drugs to maintain her blood pressure, and very sadly died 2 days later as a result of multiple organ failure, with refeeding syndrome as a contributing factor to that. Okay, so the refeeding syndrome, the kind of hallmarks of it are the biochemical features. So mainly hypophosphatemia, but also hypokalemia, hypomagnesemia. In its full-blown form, you can also see fluid imbalance, fluid shifts with pulmonary edema and cardiac failure, cardiac arrhythmias. And also the thiamine requirement in these patients is dramatically increased. So in somebody who is not supplemented, or in somebody who has a low thiamine reserve, Wernicke's encephalopathy is a potential feature. So why does that happen? So this equation here is it's a very coarse representation of aerobic respiration, and I make no apology for that, but it gives a nice representation of what happens with phosphate. So when you have somebody who's malnourished and you then feed them again, you then come into a kind of anabolic phase where there's this intracellular movement of potassium, magnesium, and phosphate because of the provision of energy. Sodium and water move to the interstitial fluid. There's increased thiamine utilization and requirement, And magnesium is required as a cofactor of the sodium-potassium ATPase pump as well. So the magnesium requirement increases as a result of that metabolic shift. So the people who are at risk, one or more of the following. So a low BMI, unintentional weight loss of greater than 15% over the last 3 to 6 months, little or no nutritional intake for more than 10 days, and low levels of potassium, phosphate, or magnesium prior to feeding, or patients who have more than 2 of the following. So a low BMI, but not as severely low, unintentional weight loss less than 10%, little or no nutritional intake, and then a history of alcohol abuse or drugs, which may include insulin, chemotherapy, antacids, diuretics, but that list isn't exhaustive. And these criteria were from the UK, NICE, around 2006, but a lot of people still refer to these today. So this is a table which is taken from a 2019 publication, just to give you an idea of just how common hypophosphatemia is in parenteral nutrition. So this was a sample of 80 patients started on parenteral nutrition, and they were stratified for their refeeding syndrome risk. So high risk on the left, low risk on the right. So out of these high risk patients, you can see that a third of those developed hypophosphatemia, with that being mild in the majority, but also one with a very severely low phosphate, less than 0.3 millimoles per litre. And even in these low refeeding risk stratified patients prior to feeding, 20% of those developed hypophosphatemia as well. So how do we manage this risk? We replace the electrolytes before starting the PN. So we make sure that phosphate, potassium, magnesium are all within reference range ideally, and we would replace at a kind of lower threshold than if we weren't starting PN. So a magnesium in the high reference range normally we wouldn't be too concerned about, but if we're starting PN, we probably are going to give just a little bit to try and bring that up to normal to manage risk. We start low and slow. We provide no more than 50% of calorie requirements to begin with, sometimes a bit less in very high risk cases on a patient-to-patient basis. And then we have to take into account calories from other sources. So is this patient getting propofol, lipid emulsion? Is this patient also getting dextrose? And also we need to remember that calories will come from those other sources. We give B vitamins, so Pabrinex or banana bags as they're lovingly known because they're bright yellow in colour. And we give them once daily for 3 days to replete B vitamins in high-risk patients. And then we make sure that we are providing adequate micronutrients within the PN as well. So that's a quick fly through some issues we get in the more acute setting. In terms of chronic patients, we'll go quickly through intestinal failure-associated liver disease. And this is something that tends to be seen more in patients who are on PN for a long time, who require it for years for things like short bowel syndrome. And abnormal liver function tests are very common in parenterally fed patients, particularly in neonates. And this was a 2013 study that showed a fifth of neonates receiving PN for more than 2 weeks developed cholestasis and cholestatic liver function tests. In short-term feeding over a couple of weeks, these changes are usually transient, and often they're not anything to do with the PN. Usually there's sepsis or drugs or antibiotics or something else that is interfering with the hepatic function. But with longer-term feeding, there can be substantial liver damage and end-stage disease. And that is one of the most common indications for consideration for actually an intestinal transplant, and sometimes a joint liver and intestinal transplant in some of these patients. So again, this just shows you how common abnormal LFTs are. So there are multiple studies in this table. So alkaline phosphatase is by far the commonest abnormality in these patients. and 48% in the top study had abnormal LFTs, so persistent elevation to more than 1.5 times the upper limit of normal for 2 of 3 out of alkaline phosphatase, GGT and conjugated bilirubin. And then also chronic biochemical cholestasis, 65% after 6 months in one study with a high lipid content in PN. So again, monitoring liver disease in these long-term patients is really very important. So we used to say PN-associated liver disease, but actually the term we should use now is intestinal failure-associated liver disease. And there's no standard definition, but this is essentially liver disease occurring in patients with intestinal failure, generally on PN, but not always just as a result of the PN. And other causes, so drug causes, other pathophysiological causes, and obstructive causes should be excluded. So some of the potential contributors in intestinal failure-associated liver disease, so patient-dependent causes, prematurity in neonates, bacterial overgrowth, decreased hepatobiliary circulation, particularly in patients who can't tolerate any enteral feed at all, sepsis, medications, all very common. Nutrient deficiencies have been implicated, so protein essential fatty acids, and choline, taurine, carnitine in some cases as well, although it's rare that they'd ever be supplemented, particularly. Nutrient toxicity as well. We mentioned glucose and lipids, but also particular micronutrients, manganese, aluminium, and then the lack of enteral intake. So this lack of normal hepatobiliary circulation, reduction of hormone regulation in the gut, can all contribute to liver disease, generally cholestasis in these long-term patients. So in terms of minimizing the risk of those complications, fat or lipids reduced to less than 1.5 grams per kilogram per day in the short term, whereas long-term PN, generally the soybean lipids should be less than a gram per kilogram per day, and switching to some of these more anti-inflammatory preparations that I mentioned with the N3 polyunsaturated fatty acids rather than entirely soybean-based. Being careful not to exceed the glucose oxidation rate, not give too much energy as glucose. Don't overfeed overall, energy or nitrogen. Introduce a trophic enteral feed. So this is just a dribble of enteral feed, so either a small amount of oral diet or a small amount of feed down the tube, but not enough to maintain energy requirements, just enough really to maintain the gut and the mucosa, and reduce the PN to cyclical feeding, which means don't give it 24 hours a day. Typically patients are fed overnight and they then have a break from that load during the day. And then liaison with the medical team regarding treatment of sepsis, review of medications, and any other of these contributory factors. Okay, metabolic bone disease as well is something that we will quite often see or get clues to biochemically. So we have here on the right severe L1 vertebral fracture, and these patients may present clinically with bone and joint pain, back pain, loss of height, fracture, but also many of them are asymptomatic, and it may well be in their bone biochemistry that we pick up the first suggestion of problems. So the underlying medical cause of intestinal failure is quite often a contributor. Glucocorticoids in things like inflammatory bowel disease being a big culprit in bone loss. Nutrient and mineral deficiencies in long-term feeding can contribute. Specific nutrients such as vitamin D, obviously being a big one in bone biochemistry. Excessive urinary calcium excretion, so either due to acidosis or due to increased PTH drive. And then also high aluminium concentrations in PN. So aluminium in health with normal renal function, it's highly unlikely that it's ever going to cause problems, despite being fairly abundant. In patients on PN, it's going directly into the vein. Also, they may have renal impairment, and it essentially impedes the border where type 1 collagen is laid down and stops that from being mineralized. So a bit of revision of the bone buffer system. So most of the body's bicarbonate is within bones, so about 2/3 of it bound to cations, and about the other third within hydroxyapatite. So in short-term acidosis, the bone will buffer that by producing sodium potassium bicarbonate, but in a prolonged acid load, you're going to get promotion of osteoclast differentiation and activation, and release of calcium carbonate and calcium phosphate to maintain that pool to grab onto hydrogen ions and buffer acidosis. And that is going to result in bone loss and increased urinary calcium excretion. So this here is a little graph from a DEXA scan, and this is one of my patients who's now 38, and she has quite troublesome Crohn's disease, and she's had multiple gut resections in the past. She's only got 60 centimetres of small bowel remaining in continuation with colon, and thankfully she's now off home parenteral nutrition, given that her gut had adapted over time and allowed her to maintain her energy requirements. But on the left is her most recent DEXA scan, and that is showing us at spine she has a T-score of about -2, so that means her bone density is 2 standard deviations below a young adult mean. And the graph on the right shows you the dramatic decline in her bone mineral density at her spine of about 15% during the time she was on home parenteral nutrition. And so that will be a combination of the nutrition, but also the underlying disease. And you can see there at between the ages of 32 and 33, 2 things happened. So first of all, around that time, she came off parenteral nutrition. And also as well, the decline in bone density had been so swift that we felt the need to intervene. And she was given bisphosphonates, which is really very, very unusual to do in a young woman unless we feel we have no other choice because of severe bone loss. So biochemical monitoring for these patients, urea and electrolytes, so renal function and electrolytes, liver function tests, calcium, phosphate, magnesium, and CRP need to be done at baseline and daily until stable. Stable inpatients, you can get away with doing it twice weekly, and at each outpatient review, which generally for parenteral patients here is no longer apart than 6 monthly. Cholesterol and triglycerides before starting, weekly initially, and then 3 monthly once stable. A baseline glucose and daily plasma glucose, and 4 to 6 hourly capillary blood glucose monitoring on commencing PN, particularly in very sick patients. So the ESPEN HPN guideline gives recommendations on biochemical and clinical monitoring. So body weight, hydration status, energy and fluid balance, and then hemoglobin, ferritin, albumin, CRP, electrolytes, venous blood gas, kidney function, liver function, and glucose are all scheduled outpatient appointments 3 to 6 monthly. Clinical symptoms and signs that might indicate vitamin and trace metal deficiencies should be evaluated once a year at least. And then bone metabolism and bone density evaluated annually or in accordance with accepted standards. And we quite often can't do DEXAs in these patients every 18 months because of pressure on the service, but that would be standard to aim for. So I'll skip through micronutrient screen just in interest of time. But micronutrients will include selenium, copper, zinc, your lipid soluble and water soluble vitamins, and then vitamin D is clearly very important in terms of your bone health as well. All of these micronutrients need to be provided in PN. In terms of screens, whole blood and red cells, we can measure manganese and vitamins B1, B2, and B6. And then iron, iodine, cobalt investigated by hemoglobin, TFTs, and B12 respectively, so more common biochemical analyses. There are multiple problems with micronutrient screens, the acute phase response, getting the correct sample type, availability of these assays as well. Often it's very few specialist centres. Contamination, particularly of trace metals in the environment. So most EDTA in blood tubes will be contaminated with trace metals. Failure of levels to correlate with clinical symptoms. And then once you get the results back, lack of experience in treating specific deficiencies, especially out with the context of parenteral nutrition. So the acute phase response affects many micronutrient concentrations, but that's independent of the nutritional status, which can make these results very, very difficult to interpret. We can use the CRP level as a very vague guide as to the extent of the inflammatory response. And this final slide, I need to give thanks to my colleague, Dr. Wadsworth, for this, who works within the Trace Elements Micronutrient Diagnostic and Research Laboratory at Glasgow Royal. And this illustrates just how much biochemical monitoring of micronutrients is affected by the acute phase response. And so you can see there with a CRP of more than 20, copper, zinc, plasma, selenium, vitamin A, vitamin C, vitamin D are all going to be really very difficult to interpret. So quite often, all we can do is to give adequate provision of these and then base specific supplementation on the clinical picture. Or in the home patient scenario, sometimes we will wait, and if there's been an acute insult or infection, we treat that, wait, and then redo the screen. So in conclusion, parenteral nutrition is a life-saving intervention in people with intestinal failure, but it's not without its problems. It's associated with both acute and chronic metabolic complications. Laboratory support for provision of biochemical monitoring is essential to any team providing parenteral nutrition and is very helpful in terms of preventing and managing the complications. Okay, so that's been a rattle through. There's so much more I could say, but in the interest of time, we'll leave it there. And I'd be more than happy to take any questions.
Yes, thank you very much, Alison, for the very comprehensive talk. And the forum is open for the questions. And I have one question for the sample collection. Do you advise any time gap between the TPN infusion and the sample collection?
Yes, so ideally we would wait 8 hours after the infusion finishing. But doing that in practice is really very, very difficult. So when we first start PN, we start patients on 24-hour feeding. So we don't like to give the full fluids, lipid glucose loads over 12 hours initially. And there's also a potential risk of a rebound hypoglycemia when you stop it. So if that's being given round the clock, it's very difficult to know when. So really, sometimes you just have to take blood from the opposite arm and hope for the best. In home parenteral patients, it's a bit easier. Sometimes they feed on particular nights of the week, and you can ask them to give it on a different night so that they've had that break to get a better idea. But 8 hours ideally, but very difficult in practice.
Yeah, thank you. Any questions from the audience? In your practice, is it the post-operative patients or the chronic patients are you practicing more frequently?
Sure. So at my roles changed a little because I moved base site back in November. So prior to November, it was generally acute inpatients. So, but within that, we had everything from post-operative. It was a major trauma centre, so we had trauma patients. We would have we had a bone transplant unit as well, so we had a lot of patients with enteral problems related to that. At the moment, my kind of inpatient work is mainly malignancy. So it's mainly bowel obstruction secondary to ovarian cancer, where they're hoping to treat with chemotherapy or you'll build up prior to resection, and then we give the PN as a bridge, if you like. In terms of the home parenteral patients, we have the Scottish Home Parenteral Nutrition Service out of the centre I'm currently working in. And I'm not working directly with that team, but I am providing input in terms of metabolic bone disease at the moment. So it's been a bit of a wide range over the past couple of years, but it's been really good to see so many different scenarios.
Yeah, so the multidisciplinary approach is the key point for the management of the TPN.
Yeah. Absolutely, absolutely. And yeah, so we have here, we have surgeons, we have specialist gastroenterology, we have dietitians, we have a team of absolutely fantastic pharmacists, and parenteral nutrition is their whole job. So we're very, very lucky in terms of the support we have, the resources we have to draw from, and also the knowledge we've got. And also Salford down in England is the sort of intestinal failure centre of excellence. So we can take advice from them in the rare cases we need to as well. But absolutely, multidisciplinary team is the way forward with these complex patients.
Yeah, thank you very much. And I invite Dr. Madhuri Vidhanpatirana for giving the thanking speech. Over to you, Madhuri.
Thank you, Dr. Dulani. So now we have come to the end of the webinar, and it is my pleasant duty to thank those who contributed to make this webinar a success. So firstly, on behalf of the College of Chemical Pathologists of Sri Lanka, I would like to thank Dr. Alison Kelly, Consultant Chemical Pathologist at the Glasgow Royal Infirmary, United Kingdom, for delivering that excellent presentation on parenteral nutrition, biochemical monitoring, and metabolic complications. It was indeed a very insightful and interesting presentation. We are confident that this webinar has proven to be immensely valuable for our trainees. We hope that we can expect your involvement in our activities of the college in future as well. I also would like to thank Dr. Dulani Jayawardena, President of the College of Chemical Pathologists of Sri Lanka, for the leadership given to make this webinar a success. Also, I would like to thank all our participants joining with us from all over the country. Without your presence, this wouldn't have been a success. So hope to see you all again in 1 month's time in a session like this. Thank you.